Good afternoon, everyone, and welcome to the Global Digital Exemplar and GS1 Standards in Healthcare presentation, The Importance of Aligning the Two Programmes. I'm Katie Wardle, and I work as part of the GDE Learning Network team at Arden and GEMS CSU. I'm delighted to be introducing Claire Clark from GS1 and Graham Evans from North Tees and Hartlepool to you today, who will be taking us through the presentation. We've allowed question time at the end of the session, so feel free to submit any questions you have using the chat function at the right-hand side of your screen. And also, if you have any technical difficulties, just drop me a personal message and we can pick those up and try and help you out. For now, though, I'd like to hand over to Claire and Graham to take us through the presentation, so thank you both.
Thank you, Katie. Good afternoon, everybody. I'm Claire Clark from GS1 UK, and thank you for joining the webinar where you're going to learn from Graham from North Tees and Hartlepool NHS Trust the importance of aligning the GS1 standards in the Global Digital Exemplar Programme Blueprint. North Tees is one of the Department of Health and Social Care demonstrator sites for Scan for Safety, the GS1 implementation programme. And given that the Trust has completed its initial implementation phase, I am going to leave Graham to share his slides and the importance of aligning the two programmes. So thank you, and I'll hand over to Graham.
Thank you, Claire, and thank you, Katie. Good afternoon, everybody. As everyone is clearly aware, that we're embarking on quite a significant digital transformation journey across the NHS, and where we can look to maximise the opportunities of alignment and synergy of programmes, then we should aim to do so. As a global digital exemplar fast follower and the demonstrator site for Scan for Safety, within our programme of work, we've tried where possible to bring together the key elements of these programmes. However, in terms of the things we'll talk through today, an overview of the work that we've adopted in the Trust so far, an articulation of why alignment is important, some of the benefits that we are seeing now and hope to see in the future, and some of the issues that we need to overcome. I guess preaching to the converted, if things like this were easy, it would have been done by now. It isn't, therefore we have to really be ambitious in the programmes that we aim to deliver. Then I'll give an indication of some of the timescales and work that we've already deployed in terms of the GS1 standards. An interesting quote from NHS England regarding the foundational infrastructure of GDEs is about making systems as easy and intuitive for the clinicians that we work with to use them. What we have to be cognizant of is if we put very robust and clunky systems in, the likelihood is that they will not be used in the way that we hope they would. So therefore, we need to think about usability and interaction for clinicians at all times. And when we can do things once rather than many times, that's the opportunity that we should grasp with both hands. Just by way of a little bit of background, North Tees and Hartlepool NHS Foundation Trust is in the northern conclave of England. We have a 3-site campus serving a population of about 400,000 people. We have a site at the University Hospital of North Tees based in Stockton, a site that we have located on the east coast in Hartlepool, and a small site to the northern part of Hartlepool up in Peterlee. We're not a massive organisation, essentially a district general hospital. We have a staffing cohort of about 5,500 and an annual turnover of just short of £280 million per year. We may be small, but we like to think that we are relatively perfectly formed. Recently, we were awarded an overall good status by the Care Quality Commission, and in September of last year, we were appointed as a Global Digital Exemplar fast follower, following the Royal Liverpool and Broad Green organisation, an accolade that we are really proud of and are really have a lot of ambition working with our West Coast colleagues. In terms of the background and how we try to bring some of these things together, I think there's a general assessment by the patients and public that we serve in that the NHS is one organisation that's unified and works in close harmony. I think the reality is, at best, we are a set of individual organisations quite often connected by quite tenuous links, and it's only when you get something like a cyber outbreak, such as WannaCry, that you do realise that we're a bit more connected than we give ourselves credit for. The work that we're looking at across the North East and Cumbria started with the model of the new models of care and how sustainability and transformation partnerships can really look at how we can learn and share best practice in a local geographic health and care footprint. More recently, the 44 STP footprints have been reviewed, and there's a programme of work now to try and bring some of those together. And for Cumbria and North East, the original 3 STPs are likely to converge into a singular oversight group called an integrated care system in the coming months. However, whilst we may have an overarching system, we still expect that delivery will be more aligned to local footprints in the form of integrated care partnerships. However, within that programme, we have an emerging and vibrant digital care programme where we bring together elements of our individual organisations and footprints into a unified programme of work. And we're quite unique in the respect within the North East and Cumbria. We have 3 global digital exemplars, 2 acute and 1 mental health. We've got an ambulance service global digital exemplar and 3 fast followers, including North Tees and Hartlepool, who are a remote fast follower to Royal Liverpool and Broadgreen. So our ambition is to move from that working isolation into a more integrated way of working, not just within our local organisations, but across the whole health and care economy. The journey that North Tees and Hartlepool have been on isn't unique, and I'm sure many organisations will recognise some of these things, but as far back as 2004, we were one of the early trusts to adopt some of the National Programme for IT services. And if I can be bold to comment, that one of the views that I had why the National Programme for IT didn't get the traction or the credit it deserves, it was branded a programme for IT as a programme for health and care transformation. So we almost set that programme up to a large extent to fail in some respects. North Tees and Hartlepool were one of the early sites to implement trust-wide Wi-Fi for mobile working internally, deploying things like computers on wheels to give clinicians opportunity to work where that's appropriate rather than be constrained by technology. We implemented electronic document management 12 years ago, digitising paper-based case notes, and we moved a lot of care and some of the technologies that enable that out into the community services. Between 2009 and 2016, we'd already improved some of our digital maturity by implementing electronic order comms and results. We were connecting to the broader health and care economy to share things like pathology images and, radiology images across technology such as image exchange portal between care providers. We were quite forward-thinking in the implementation and adoption of the summary care record, and we did lots of things like providing GP electronic discharges way ahead of the national mandates. Towards the end of 2015, in October, we went live with the first phase of our electronic patient record programme, and we replaced our core clinicals and patient administration system with an enterprise-wide solution. And the product that we implemented was a technology called TrackCare, delivered by InterSystems, who are our vendor. The interesting note to be aware of is that the adoption of TrackCare for ourselves was the first of type English edition. TrackCare has been used widely across the globe, quite predominantly in Scotland, but in order to take a product that needed to be used in the English NHS, as a first of type organisation, we anglicised the product and its capabilities. And as you can imagine, being the first of type is very much like being a pioneer in the Wild West. Quite often you get your backside full of arrows, so we've got quite a few battle scars, but I am pleased to say some of that investment and hard work is now paying off. Between 2016 and 2018, I arrived back at the Trust in July of 2016, almost 2 years ago. We started to develop some new ambitions and intentions aligned to our digital ambitions. This includes the voice over IP telephony, self-service kiosks for patients, collaborative video conferencing that we can use internally, and then long-term out to the general public. As Claire mentioned, we were appointed a Department of Health Scan for Safety demonstrator site, one of only 6 in the country. And we also provided lots of leadership in terms of how we can work together in our local geographies and try and demonstrate where we can, sharing and learning and best practice. So quite a lot has happened over the last couple of years. Then as we move forward between next year and 2021, we're going to deliver what we've termed our digital hospital of things. We have a high ambition to remove paper. I've got to be honest, I don't think we'll ever get rid of all paper, so paper light as opposed to paperless will be something that we'll be very pleased to achieve. We've developed some internal services and systems such as CareScan, which I'll talk to shortly, and we'll be implementing subsequent phases of our electronic patient record system, including business intelligence, automated services, and connectivity to the broader health and care system in Cumbria and the North East, delivered through a programme called the Great North Care Record. And all of that is articulated in a very simple 20-page document entitled Our Digital Growth Roadmap. Where we're heading, I think most of us on the call will recognise some of these things, but we are heavily dependent on paper. We've got lots of archaic technologies that we really need to get rid of, such as fax machines, printers, plethora of different paper-based systems, and we spend a fortune on stamps sending correspondence to patients and other organisations. So we really need to think about the consequences of our paper legacy. Paper is by no means safe. We can't really record very easily when we have data breaches. You know, many of us will have had experience where letters going out to patients, you've had 2 letters stuck in the same envelope, letters have been lost in transit, and there's no audit trail. So we really need to be thinking about getting rid of some of this stuff and using digital first as our primary channel of communication. So our ambition is to move from that very paper-heavy world into paperless, but I'll certainly accept a paper-light environment. But with the removal of paper comes some additional and new threats, such as the increasing cyber threat. So whatever we do and whatever we build, we need to build systems and controls and security into the new digital services as an integral way of working rather than an add-on. And this is where the real opportunity comes from our work as a GDE fast follower. And in particular, how we can share and learn from some of these programs that may have advantages or opportunities in complementary programs such as Scan for Safety and the GS1 implementation. So we shouldn't be reinventing the wheel. We should look at opportunities to do things once and share many times. So we absolutely are committed and are behind the principles of the GDE approach. As I mentioned, our GDE partner is the Royal Liverpool and Broad Green Hospital Trust. We see this as a partnership, and the real unique selling point for North Tees and Hartlepool versus the work that Royal Liverpool and Liverpool Women's will be doing is we've already deployed our electronic EPR, which is certainly part of the Royal Liverpool trajectory and opportunity. Whereas what Royal Liverpool have done that we haven't is they've really removed a lot of paper, and they've got quite unique and specialist programs of work that we are quite envious of. So it is a partnership. We will learn and share from each other through the vehicle of blueprinting. And there's a great opportunity to do this, not just between GDEs and fast followers, but also all other organisations that can learn from some of this work and vice versa. So we're really enthused and really, conscious that we need to get together, stop reinventing the wheel, and share as much as we can. The fundamental building block of our EPR journey and our GDE journey is the electronic patient record. And as I've already said, track care becomes the real platform. But like many organisational changes, if you always do what you always did, you will always get what you always got. And a great quote from Bill Gates is about how you automate efficient operations. So if you put technology in to something that works well, the benefits will be amplified or magnified by those new ways of working. Conversely, if you implement or automate an inefficient system, then what you will see is a magnification of that inefficiency. And what that tells me is, don't just do what you've always done. Look to re-engineer those business processes and those systems to give you a better way of working. And as I say, this becomes the fundamental building block of our EPR and GS1 journey. We've got lots and lots of work that is ongoing. Phases 2 and 3 of our EPR implementation are in train now. So in the recent past, we've implemented a replacement of our legacy theatre management system. I have to say that the implementation of that particular module was far better than the previous modules. We're learning as we go along. We're starting to adopt and adapt to new ways of engagement and new ways of deploying those services. More recently, we had to quickly implement the new A&E emergency care data set. Clearly, there was a national mandate to do that, to collect the relevant information assets for sharing nationally. Again, that went through with quite a painless operation, although this isn't an easy thing to do. And more recently, we've implemented electronic prescribing and medicines administration, and there's a very clear correlation between that and the scan for safety type initiatives. We've now deployed very quickly 8 wards. We're about 45% into that deployment timeline. We are literally rolling out an EPA-enabled ward 1 every week. So it's a very ambitious and very quick deployment methodology. We've used the principles of cookie cutting. We're not going to reinvent the wheel. We're going to deploy a standard way of working and then literally roll that out quickly across the whole organisation. In addition to those internal pieces of work, we are heavily involved in integration with the broader health and care system. So we're looking at how we can send electronic correspondence out, receive electronic correspondence and communication between our various stakeholders, including neighbouring organisations, where there is absolute opportunity to share information in real time, given that we will be looking to serve the same patients quite often with the same clinicians. We've also deployed some recent innovations in terms of electronic clinical handover, and the advantage of having something like an electronic patient record has meant that we haven't gone out to the market and purchased additional systems. We've actually adopted the functionality that existed to create those new and beneficial ways of working. So all in all, that's been a really ambitious and beneficial program. And then there are a whole raft of external and in-flight projects that link to our GDE ambitions and the work around how we work in a more collaborative way across the whole region. Fundamental to the way that we've done some of this is our internal and external communication program, sharing examples, case studies, blueprints with organisations within the Track Care English Edition user group, but also internal organisations across the region and elsewhere. So that's basically the story around our EPR. Fundamental to what we're delivering is about getting the basics, the hygiene factors right. And we had an ambition as an organisation probably 10, 12 years ago to create a new greenfield hospital halfway between our current organisational establishments. Unfortunately, at the last minute, we weren't able to secure the funding. What that has meant has been that we've now got to deploy some of those ambitions and ideas in hospital buildings that are 50 years old. And as many colleagues will be aware, that in order to implement some of those things in an old fabric or infrastructure, it's not easy. But the way we've started to do that has been get the plumbing right, get the basic infrastructure. That includes networks, Wi-Fi access, to build the basic connectivity within the ecosystem of our hospital buildings. And from there, we can then deploy our new systems and services such as EPR other clinical systems as that becomes necessary and appropriate. What it also means is we can readily and quickly deploy new services such as self-service kiosks and other technologies such as Wi-Fi connected systems and applications. One of the basic opportunities there has been not only getting our internal connectivity and infrastructure right, but providing the capabilities to connect to the outside world in terms of collaborative effort. And I'll touch on in a second or two how we're sharing internal information and receiving external information as an integral part of our electronic care record through various technologies and footprints. And that again creates the opportunity in the future to connect to things such as the Great North Care Record. Implicit and embedded in all of this is the creation of standardized ways of working and patient safety as a prerequisite. And this is where the Scan for Safety program has really come to alignment with the GDE ambitions and objectives. And when we started to look at some of the principles that we need to deploy and adopt, it became very evident very early that there aren't systems out there that would deliver some of the things that we wanted to do in the timescales that we wanted to do it in, which has meant that we've actually deployed and developed our own applications and services. And I'll talk about what we've termed our CareScan product shortly, but this was really in recognition and acknowledgement that what we wanted possibly doesn't exist elsewhere, so we've actually created something ourselves that we feel will be really instrumental in enabling what we've termed the hospital of things. But this is only one part of a bigger picture, and as we move to more unified and integrated working across the health and care system, what you really need to have is an ecosystem within your organisation that allows you then to interact and interoperate with other parts of the health and care system. As I've mentioned, one of the opportunities that we now have is to receive primary care information through a real-time information exchange directly into our integrated electronic care record within the organisation. And we've done this with existing and proprietary technology. We haven't reinvented the wheel, and we've done this across the whole of Cumbria and the North East. So as part of the urgent and emergency care vanguard, one of the things that we really wanted to deploy quickly was information in secondary care that's derived from the primary care patient record. And the way that we did this within North Tees and Hartlepool is to create a contextual link within track care to allow clinicians very quickly to access those primary indicators such as investigations, medications, diagnoses, etc., to stop having to use things like faxes or pick up the telephone if a patient presents that we need to make some informed decisions against. So again, an example of joined up healthcare and joined up thinking. And this is already in place. Long term, we expect this will be replaced with the platform that we've termed the Great North Care Record, where we can really then start to look at how information around the patient can serve a multitude of different services. Clearly, we've got to consider information governance and consent, which is fundamental. But what we will then be able to do is to look at how we can use that joined up healthcare on a large scale to inform the public health agenda, how we can start to create health and care interventions based on population health, and how we can then give patients more access and control of their information to allow them to change things like their lifestyles and the way that they go about self-managing. So it's a really important piece of work, but without having those fundamental building blocks in place, it's really just an academic exercise. So you've got to get those primary building blocks established and in a robust way in order then to build the skyscraper on top of it. We've got a very comprehensive program around the digital hospital of things. It has a number of themes such as putting information at the heart of decision making, providing patient and clinician self-sufficiency and self-service, moving toward that utopia of paper-free or paper-light working, giving clinicians the tools and technologies to allow them to work in a productive and effective way, and then having that infrastructure to take out some of the bureaucracy and clunkiness of the multitude of different systems that many of us have seen and have experienced. All of this needs to be set in the context of governance, and we're in a very fortunate position within North Tees and Hartlepool. Many of our programme governance committees and boards are chaired by clinicians, from our medical director who chairs our digital strategy board, through our chief clinical information officer who chairs our clinical informatics group, and a number of others. So we are really, really fortunate that we've got clinicians who are leading and driving this transformational programme of work. All of it is underpinned by very robust programme management and governance, and those of you that are party to the GDE programme, you will probably accept that we are being really viewed from on high to make sure that we not only say what we're going to do, but we can demonstrate cohesive delivery against agreed timescales and plans, which is right and proper. And what it does, it instills a very robust discipline on how we roll some of these programs together. Part of the work that we've been leading on and have implemented over the last 3 or 4 years has been recognised. So the recent announcement in February of the Clinical Digital Maturity Index has moved North Tees and Hartlepool from a position of around about 121st nationally up to a joint first position with a CDMI score of 95%. And this is all in relation to the work that we've looked at some of those digital maturity aspects and built our programs around delivering enabling activities that drive us towards that 100% threshold. Now, it's going to take some time to get there, but once you start seeing some demonstrable evidence of progress, it is a bit like Field of Dreams. People get enthused, they can see that there's a benefit arriving, and therefore they get behind and support those programs of work. We have an ambition articulated in our GDE program that will move us from our current position through to financial year 19-20 to achieve circa 100%. And that's demonstrated in a number of individual programs that are very clearly governed and managed. And if you're not measuring some of those deliverables, then it's very difficult to control and oversee. So our program governance is really important to the success of these work streams. Our key strategy is about interoperating, be that internally as a trust or externally with the wider health and care system. And like many organisations, we started off with a smorgasbord of different clinical systems, loosely connected by quite old and sort of not very robust trust integration capability. So the first steps that we implemented was to tie some of these things together with a more industrial strength organisational integration engine, and we've deployed InterSystems Ensemble platform. And from that, we can start to really see some demonstrable improvement in our digital maturity aspirations, and we are tracking that back to the Digital Hospital of Things program. When we then started to look at how an EPR could remove some of the burden of that legacy, you start to get a more concentrated and converged technical infrastructure. And from this point, this is where the real opportunities arise from, because then you can really start to look at how you can then interoperate and connect with the broader health and care system using agreed and approved standards such as FHIR. And then before you know it, health and care along a seamless information backbone becomes something that's real rather than just something that we dream or aspire of. So from a northeastern Cumbrian perspective, that sort of topology is the way that we are trying to roll out some of this interconnectivity. At a more localized level, in the Tees Valley, which is sort of circulates around the North Tees, South Tees and County Durham and Darlington areas, we're also looking at how we could deploy something like a localized health information exchange to share information on a more locality basis. And although this is just early days at the moment, we can really start to see now that if we can do some things quickly and seamlessly on a local level, including how we can then use information and insights to inform new ways of working and new care plans and platforms. We really see a real opportunity that we haven't really grasped so far. So again, this is part and parcel of our GDE program of work. It certainly isn't finished, and we are on the early stages of that journey. But I think we are now not limited by the technology, but we may be limited by organisational sovereignty and some of the cultural things that we need to overcome as we move forward. But I do feel personally that digital transformation will be really enabled once organisations really think about how they can add value in terms of their collaborative efforts. And I fundamentally believe that this is key. So once you've got that internal infrastructure in place and the opportunity then to share information bi-directionally, you can then really look at how patient flow and staff flow can really be transformed. And it's not about thinking this is just all about my organisation. It is about thinking about system rather than organisation. And this is just an illustration that how we can use the capabilities around a hub and spoke type of model to not only share the information around a patient, but utilise the clinicians that will be delivering that care. Care is about what we do, not necessarily where we go. And if you can use that mantra, technology can enable that virtual way of working, perhaps some things that we've not really considered in the past. So we'll be serving the same patients with the same staff. Wouldn't it be really good if we can converge and use the same systems where that's possible and practical? And then beyond that, you can then really start to think about how shared IT services and back office services could really transform and really make both the efficiency and effectiveness of our healthcare system a real and tangible way of working. And this is where Scan for Safety and our GS1 ambitions come in. So, this is a real challenge now, and I think if we keep working in an insular and siloed way, we don't learn from the best. We've seen some of the challenges that, harm will be done to patients, and therefore, if we can concentrate our effort and share and learn, it is absolutely the right thing to do, not just from a safety aspect, but also around efficiency and cost saving. And it's really good to see that our Secretary of State, Jeremy Hunt, is absolutely behind this. And it is about getting it right first time, rather than trying to fix something that's broken. Let's prevent it from being broken in the first place. Not only Jeremy Hunt, but Lord Carter, refers to how we can optimise the way we work by removing unwarranted variation. We can look at using connected systems and services to prevent things like drug errors, medication errors, and how we can then use technology and digital information to serve things like financial modelling. So again, it's all part of a bigger picture and how we can then transform health and care. It has been mandated in the Department of Health procurement strategy, and the supply chain is fundamental. So if we can use the same terminology, make sure that our suppliers are using the same common codes that our receiving systems understand, we've got a better chance of delivering a real difference rather than being separated by a common language. So standardization needs to be at the heart of what we're doing in terms of how we refer to a patient, a product, and a place. Again, as I've mentioned, part of the challenge is not just to have an informed way of looking back when things go wrong, and we've got many examples of that. That will be a benefit to get timely resolution, but perhaps we really need to think about stopping those things from happening in the first place, rather than thinking about how we fix something after it's already been broken. So in terms of deploying some of these things, and back to that common terminology, common vocabulary, whenever we refer to a person, we need to think about a particular global service relation number, a unique identity of a member of staff and or a patient, how products are named and termed using the same conventions, and how locations or places can also be adapted to use the same nomenclature and terminology. And those are the key things that we at North Tees and Hartlepool are principally interested in. Again, getting those basic things in place, the basic building blocks, before you start to build other more innovative and sort of transformational services on top of that. So we also need to make sure that we get the right information in the right form. I think I'm probably going to be repeating myself here, but traceability when you need to do a product recall is about having the right information at the beginning, making sure that the patient has unique identification such as the NHS number, and that's built in as an integral part of the barcoded wristband. So you're not having to have duplex systems or multiple systems. Every data item or every data element is in a common coded barcode. The industry has done this, for many, many years now, and ironically, the NHS is really starting to catch up. So if you go to any supermarket or even small grocer's store now, unique product identifiers are the norm in order to then compare like with like, and the NHS should be no different. So the concept of a global trade item number is one of the key and principal building blocks. Making sure that barcoded identifier contains the uniqueness of the product, its expiry date, its batch number or lot number for traceability, and a unique product serial number. Again, that can be embedded in an implicit barcode that can take many different shapes and forms, but until you get that principal way of tracing those key data items, the rest of it is just academic. Again, the phrase, we're sort of separated by a common language. We can have different systems or different products, but they may actually have the same name. So in order to make sure that we differentiate, having that unique device identification is absolutely fundamental to the security and safety of what we want to roll out. And the coming EU legislation for those unique device identifiers for medical devices will be one of the opportunities that we then need to embrace and deliver. So not calling the same different things by the same name, the same things have to have a common name that universally is accepted by all organisations within that supply chain. The global location numbers allow organisations then to identify particular physical environments, physical locations, from healthcare locations through to storage locations and all parts in between. That will allow us to create that visibility and traceability of the point of use where those systems and services and products were actually being used for healthcare, infection purposes, and so on. So again, looking at that whole supply chain from how it's manufactured all the way to the point where it's consumed and all points in between. Really important in terms of the supply chain traceability. So in terms of the progress from North Tees and Hartlepool, from the global location numbers, all areas in our trust are now identified with that GLN barcode. From the service relation numbers, again, we've deployed that throughout all areas within the trust. And the global trade identification numbers, all class 3 products, are now incorporated in that GTIN scope, and we're transferring that into the way that we use stock and the way that we can then scan into the patient's record going forward. So within a couple of years, we've moved absolute mountains to demonstrate the benefits and the delivery of this program of work. I think just very quickly, it started back in 2014, following the mandated procurement strategy, and because we've had that central mandate to do things quickly, as an organisation, we've not had any real resistance. This feels, from a clinician point of view, and my clinical colleagues tell me that this is absolutely the right thing to do from a patient safety perspective, and we should have been doing it many, many years ago. So I think from a transformational and buy-in perspective, clinicians absolutely get this and are fully behind it and supportive. So this is just a very quick slide in terms of, it starts off by that mandate. There are very clear and demonstrable opportunities around patient safety, including things like reduction of our insurance policies by getting some of these services and controls, being able to measure some of those deployments and deliveries and share with the wider NHS through that blueprinting process, and then use some of that opportunity then to, from an internal perspective, reduce waste, lower those stock levels, where appropriate and capable, automate reordering, and that then in itself creates that opportunity to release time for more clinical care by taking some of the sort of clunkiness and routine stuff that we've done time and time again and use the system to drive some of those efficiencies and opportunities. But it is all about the patient and it's all about the standard, and this, I can't take any credit for this slide, but in essence this slide describes the patient journey from arrival through to discharge, and in the event that something went wrong, the sorts of things that we could do in terms of a product recall to either get the patient back quickly or alleviate some of those worries or anxieties that if there was a product recall that the patient was worried about, we could very quickly advise that patient that there's nothing to be worried about, or in the worst case, actually there is something, you've been identified, and we need to get you back in to do some retrospective work on yourself. So it does give you that quick single point of access once you start collecting data at the front end of the process. However, my view is that that's really sort of closing the gate after the horse has bolted. If we can use the technology to prevent those things from happening rather than a reaction to them happening, that would be my fundamental ambition. And this is where some of the challenges have come in. So we've got lots of different barcode sources, not just for this particular program of work, but things that we were already doing. And our idea and ambition aligning this to our GDE program is to start using single ways of working, single ways of data capture. And many of you will be familiar that once you start looking at some of these technologies, there's a whole plethora of different barcode readers, wands, and so on. And before you know it, the staff that need to interact and operate some of those things are becoming overwhelmed by the multitude of different systems or services. So again, by using a more unified way of working, our intention is to concentrate those on a fewer, more practical ways of working, rather than have clinicians, nurses, doctors juggling different handheld devices, because clearly that won't work and you're almost setting yourself up to fail. That's been one of the principal drivers of our work. Keep it simple, keep it practical. And the opportunities around, well, could we look at what third parties can offer out there? And when we've tested the market, we found that there are many systems out there that can do many of the things that we wanted to do, but they weren't providing any standard ways of working. From what we've seen, they were very limited to use and, more importantly, limited in terms of how we could administer them internally. They had limited functionality, and what we could see, they weren't really capable of internal integration, which would lead to inefficiencies. As I've already said, many of them required a different type of data input technology, and we really need to try and remove some of that, that burden. Lots of them would require ongoing supply costs on a recurrent basis. And, like many organizations, we don't have a Swiss bank account to pay for this stuff. So we really need to think about the ongoing benefit and how we can reduce operational costs rather than keep adding to that cost base. And what we would often find is when we've looked at some of those external technologies, in terms of the benefits that we were expecting, many of them couldn't really articulate how those would be delivered. So it gave us a few alarm bells. Clearly, if we have unhappy users, then the likelihood is that we'll get poor adoption, and that would feel wasteful for both patients and the taxpayers that we serve. So our view was, do those solutions exist? And from our research, the blunt answer was no, or not that we could see. So we started to think about, could we produce some of these systems and technologies ourselves? And could we look at something that would be able to capture real-time information as a consequence of current business process, rather than adding in new and other processes? And could we immediately use that as a way of preventing by creating alerts, rather than implementing a look-back or a recall? And more importantly, how we could then use some of that information, connect it to our other clinical and administrative systems to improve our business intelligence reporting, and connected ways of working. Now, like many things, I think the technology is only one part of this solution. We've really got to consider the processes and how we can re-engineer some of those processes. More importantly, how we can bring people along with us, the hearts and minds, the cultural aspects, to change the way that we work. So really, we've thought about this is about workflow and opportunity rather than those technology systems themselves. So we came up with a bit of a blueprint on how we would design this going forward, and we wanted to make sure that we could positively identify our patients, in the similar way positively identify our staff. If a member of staff is going to perform a particular function on a patient or an intervention, has that staff been trained? And if not, do you want to stop the line or seek additional support in terms of somebody that would be supervising that staff to give that extra level of assurance or security? Could you use the same process to obtain patient consent in real time? And can you match competency and training with the role that needs to be undertaken? Clearly, if you're about to administer a product that's expired, then you really want to stop that before it's happened. So again, can you build some of those checks and balances? And similarly, if you have a product that's been recalled, but is still sat on a shelf in a clinical area, you want to stop that from being administered. So lots of other opportunities that would come out here. And alert somebody, a practitioner, when a medical device is going to be used which has something wrong with it or an abnormal status. So those things really set the blueprint that then allowed us to create an internal set of services or applications that we've now branded CareScan Plus. Those design factors and some of the fundamental characteristics of that were we've engaged and used our clinician champions to help shape what this would look like. It's about how we standardize that point of care scanning workflow, because clinicians doing a multitude of different things don't want to do the same things multiple times. Do it once, serve many purposes. Make sure that it's simple and easy to use to capture that information instantaneously. Use real-time alerting. So when you're going through the checkout at Tesco, you hear the bleep, bleep, bleep. You actually get bleep blindness. The idea of hepatic feedback would be that whilst you're listening to those bleeps, if something is abnormal, you'll get the bleep, but the handheld device will also vibrate violently to tell you that something's not quite right, to stop the line. And again, using some of those human controls and that psychology has been part of our design strategy. How you can then collect that information and use it for reporting and audit capability, as we've said, making sure that it aids clinical supervision and the management of those trainees. So if a patient is being treated by a member of staff that's in a training program, not only is the trainee learning, but the supervisor has input and control over the overall piece of work. And it aids those acuity assessments that clinicians are doing day in, day out. So it really provides value for both our patients, but also our staff in the way that we're working. Capturing the information is one thing, making sure that we can then report against that in our various reporting capabilities about product utilization, the locations where we are deploying some of these services, how much it actually costs to deliver those services from the data that's acquired through the bills of materials, using this information to inform our training records, keep that contemporaneous in real time, triggering alerts and alarms, and when things go wrong, use this as part of our integrated incident management process, including things like product recall and anything else that we can think of as we move forward, because I think this is only the start of our journey. There will be things that we haven't even considered that we can then build in to the products and services. The benefits of doing this ourselves are really around we retain the intellectual property. We have built the technology on open source platforms, so it's not restricted or constrained in how we then roll that out. It is about pushing those open standards, not being constrained by a particular standard. So we've got universal standard capability, including GS1 and Article Numbering Association standardization. It does run along and is embedded with our other clinical systems. It is sustainable, it's definitely scalable, and you can extend that to other services and ideas. And it ultimately is built by the NHS for the NHS. Some of the future use cases, I don't intend to go through some of those in any detail, but is about integrating with our medical records so you can track and trace, and clearly our digital work is implicit to that. Making sure that you have a unique identifier that spans the whole supply chain. If you can then adopt and adapt some of those capabilities, such as closed-loop management of electronic prescribing and medicines administration, they are just a few of the future use cases that we're considering. And transformation isn't just about the technology. I do believe that you do need to align the people, the engagement, the awareness, the leadership, the process, understanding where you are today, where you want to be in the future, and then you can develop future target operating models. And my fundamental view is this is an area that the NHS doesn't do very, very well. I do think the technology is a little bit easier now than it has been in the recent past, and therefore people and process are probably areas that need to have the more fundamental consideration. And as I said earlier, if we always do what we always did, we're likely to get what we always got. Therefore, transformation is about not just doing the same thing better, but doing a better thing. We do think harnessing clinical leadership is fundamental. In the Scan for Safety programme, our Deputy Medical Director has been leading from the front, but this is typical of all of our other change programmes. Getting our Medical Director, our Chief Clinical Informatics Officer, our future Chief Nursing Information Officer to lead the vanguard in this transformation. My strapline at the moment is about work with the willing. Those clinicians will make it happen, supported and enabled by the technologists. Clinical engagement is absolutely the key critical success factor. We've articulated that in our digital roadmap. It's implicit within our GDE programme, and it's part and parcel of our CareScan programme. And ultimately, this will lead to the way that we work being good, if not excellent or outstanding in the future. So convergence is about making sure that you bring together all of those things. It has to be patient-centred, focusing on safety, quality and efficiency. Use the principles of blueprinting to share, learn and spread what we do, and focus on the transformation, not just about the technology, but people and process with equal balance. If we do that, then the intent is from an internal or an external perspective, you'll move from being very siloed in the way you work through to becoming more integrated, and technology will be the key enabler. I've probably gone 5 minutes over. Hopefully that will suffice Claire and Katie.
Thanks, Graham. That was really interesting, and I'm sure it's given people a lot of things to think about and to take away. We've had a couple of questions. The first one is, you talked about needing to re-engineer the system because it wasn't very efficient prior to translating that over. So what support did you get to do that from different teams, and how much time did that take?
That's quite a tricky question. It depends on the use case. So if there's something that is relatively straightforward and in particular clinicians get it, then the time to implementation can be quite short. However, if there's something which is more complex, requires different people to contribute, then it does take a little bit longer. But I think the trick is to describe what the future state looks like, have a compelling case for change drafted, and then actually get clinicians to articulate the benefits to their colleagues and peers, both internally and externally. I can't really say that there's a definitive timeline. It is situation dependent, but the key trick is to get clinicians to articulate the benefits and the improvements in those processes being re-engineered.
Great, thanks. We've got another one talking about, you're saying about people using the same sorts of systems across different environments. Have you had any discussions locally through the STP or anything about adopting similar systems?
We have many conversations, and I think, unfortunately, this is where organisational sovereignty can actually get in the way of collaboration. So from a Scan for Safety point of view, we've shared what we've been doing around the region with our GDE colleagues and every other colleague or organisation across Cumbria and the North East. I think adoption and adaptation has been a bit slow in the uptake. Unlike when you're working with other demonstrator sites, I think there's a bit more acceptance. But generally, from a deployment of common technologies perspective, I think in the NHS we suffer from, if it's not invented in my backyard, I want to reinvent it. That's been more of a challenge, and I think hopefully as we move towards more integrated care systems and ways of working, that we need to put some of that sibling rivalry behind us and, you know, rather than reinvent the wheel, take someone's good idea and tune it to make it a bit better. It's not an easy one to answer, Katie, if I'm being honest, but, you know, I think GDE blueprinting will help, but there are lots of organisations that are not part of that GDE community, so we've got to be careful that we don't create a two-tier system.
Yeah, I think you're right. I think as well with the fast follower stroke partners coming on board as well, it's about really embracing everything that's going on and trying to spread that as widely as we can. And know that at the top they're looking at making sure that that happens. So.
Absolutely. And my final comment on that is some of the non-GDE organisations have got fantastic things that we need to know about. So this is a two-way street, and we need to try and use that as an opportunity as well.
Yeah, that's for sure. Lovely. That's all the questions that we've got for the moment. So I'd like to just say thank you to Claire and Graham for that presentation. It's been really interesting. What we're going to do with these slides is upload them to the NHS Futures website. So you'll have the recording there, the presentation and an overview of what's been said so everybody can access that. If there's other organisations that would be interested in sharing any projects or programmes of work through the webinars, do get in touch with us at the GDE Learning Network. You should all hopefully have access to our GDE email, so just drop us a line and that'd be great. Also, if you've got any feedback on this webinar, we'll be sending out a survey monkey just to find out what your thoughts were, if there was anything else that you'd like to hear. We've got one of the ambulance services coming up soon with a presentation on their approach to GS1, so that should be really interesting. So please do keep in touch with us. And I'd just like to finally thank Claire and Graham again and hope to see you all online at the next webinar, which is this Friday on cybersecurity. Thank you, everybody.
Thank you.